Go ahead and get started. Welcome everybody to Medical Grand Rounds today. So before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others, whose histories, languages, and cultures continue to enrich our vibrant community. I'm really delighted to reintroduce Dr. Monty Ghosh, who is a member of our academic department. So Monty is a general internist and addiction specialist. He works with multiple community-based not-for-profit organizations to provide support for marginalized populations, including the Calgary Drop-In Center. And he's actually doing this from Calgary today. So thank you again, Monty. He also helps foster and create unique programs to support those living with substance abuse, experiencing homelessness, and other vulnerabilities. He's the medical co-lead for the AHS Rapid Access Addiction Medicine RAM program and medical director for the addiction inpatient services at the Foothills Medical Center, Rocky View, and South Health Campus hospitals in Calgary. With the University of Alberta, he is assistant professor as well as with the University of Calgary and is involved with provincial policy building in Alberta as well as with research, and is the primary recipient of grants from Health Canada, Alberta Innovates, Alberta Health, and CIHR. He co-chairs AHS's Vulnerable Populations Task Force, and he's the co-chair of the Canadian Network for the Health and Housing of People Experiencing Homelessness. So really important topic today, and I know he's got a few panelists with him, so I'll let you all decide how you're going to introduce each other, and we will go ahead and hand it over to Monty and the panelists. Thank you.
Thanks again, Dr. Christin, for having me here. And I'll quickly let my panelists introduce themselves. I think that's probably the best way to go, starting with my co-chair for the task force, Isabel. Isabel, want to give a
Sure. Isabel Henderson, Executive Director of Special Projects with Alberta Health Services, and also co-lead on the health system integration portfolio. And more importantly, co-chair with Dr. Ghosh of the Pan Zone Vulnerable Population Task Force.
Thanks, Isabel. I'll pass over to Jacob.
Hi, good morning, everyone. I'm Jacob Ben-S, and I'm a program lead for Edmonton Zone's Vulnerable Population Support Program, and I provide the funding to the Respite to Recovery program that Radius operates.
And then last but not least, Dr. Francesco Mosaico.
Hi, Francesco Mosaico. I'm a physician and the medical director of Radius Health, formerly known as Boyle-Macaulay Health Center. And our program has the Respite to Recovery programs under Radius's auspice, and Radius staff are providing the services for that program.
Thanks again. So glad to be here. We've got a packed agenda. First and foremost, though, I want to acknowledge the fact that we are on Treaty 6 territory. And again, grateful to be here as a settler and thankful for the opportunity to be here. This is my copyright slide, a few disclosures, nothing really to disclose here for this presentation, but these are our objectives for today. So we're going to talk about homelessness by defining it, talking about approaches to dealing with this population group, talk about the evidence for medical respite, then also, of course, now introduce the new Respite to Recovery program that's operational here in Edmonton. If we do have time, I have some wastewater stuff. I know that was part of the objectives when the email got sent out, but we might not have enough time today, and so I'll keep that for another day. So first and foremost, what is homelessness? There's tons of different definitions out there. These can be people without accommodation, people living in temporary housing or crisis accommodations, such as people in transitional housing, hotels, or encampments or camping. It could also be people living in severely inadequate or insecure accommodations. So this includes people who are couch surfing, living with family and friends, or living in homes that are unfit for human habitation. I've met many clients who live in basement suites, for example, that are just basically a basement. We're not talking a suite. There's no kitchen there. It's a concrete floor, undeveloped, things like that happen. And also, this population is non-ubiquitous. They're quite heterogeneous in its nature. So these who live with mental health concerns. They have substance use concerns as well. People who are involved in the justice system and the transition from going from the justice system and corrections into the community, those involved in the sex trade, as well as people with cognitive concerns or delay, and then sexually, cultural, gender marginalization, people who live with that. So there's a variety of factors that bring people into homelessness. These are the sort of the big three. There's structural factors, such as a lack to adequate income, affordable housing, and health supports, as well as discrimination. Systems failures, which includes transitions, essentially. So these are people who are going from child welfare into the regular system, people who are leaving hospitals, corrections, mental health facilities, as well as treatment facilities for addictions, as well as individual circumstances. So this includes traumatic events such as house fires, personal crises, so people who are fleeing domestic violence, as well as people who have, again, mental health and addiction challenges, including brain injury and fetal alcohol syndrome. When you look at the odds of going into homelessness, there's obvious ones such as eviction, for example, that are quite high in terms of the odds of going into homelessness, but there's other factors as well. So this includes people who are in marginalized communities, discrimination, so ethnic minorities, adverse childhood experiences, which I'll talk about in a bit, but also psychiatric health problems and physical health problems, which is much lower on the list, but still there. So before I dive into a bit more of the adverse childhood experiences piece, I just want to quickly touch on trauma. I know I've given this talk a few times over, but I'll just do a couple slides on it. Trauma comes in various forms. It doesn't necessarily equate to the type of response from trauma, and it's very much a subjective experience. It can be both emotional and physical trauma of a variety of senses. And my favorite definition of trauma, or the favorite way to sort of evaluate trauma, is through SAMHSA, so the Substance Abuse and Mental Health Services Administration perspective. And so the way that they sort of view trauma is through what's called the 3 E's. So it's an event, so the actual threat and extreme threat of harm. It's the experience of the event, which can differ from person to person, and the effect of that trauma, so the manifestation of that trauma, which can occur immediately or slower, or be slower in nature. So an event could be something like people fleeing a refugee camp, for instance. So, we had the Rohingyas leaving Myanmar and going to Bangladesh. So there was an event that occurred causing them to flee, mass death, destruction. But the experience of that can differ from person to person. So for example, a child who's 3 months of age in their mother's arms fleeing that event might have no recollection of that event, whereas their 8-year-old sibling would have a different interpretation of the event compared to, say, a 17-year-old sibling as well, who would see things from a different lens and might have more resiliency built into them to deal with that event. And so that the way that manifests is through different effects. So the trauma, the way that the people deal with the trauma can be very different from that person to their siblings, for example. So that's important to note, that even though there might be an experience of trauma, that the way that it manifests does not necessarily translate to the severity of that experience. And the other thing I want to highlight is trauma is very prevalent. So we know that 50-70% of women in psychiatric hospitals have experienced whether either physical or sexual trauma. 40-60% of women receiving outpatient mental health services have experienced trauma as well. And then 55-90% of people with substance use disorders, women with substance use disorders, have both physically or sexually abused or both in their lifetimes. That's a huge, huge number. From personal experience, talking to my patients at the Calgary Drop-In Center, for instance, I would say at least 50% of my population has experienced trauma in some way or fashion. It's something that we try to screen for, and it's highly, highly prevalent. It's something that we need to be aware of. And we know that adverse childhood experiences has a huge impact on the overall wellness of this population group. This is the sort of landmark study that looked at adverse childhood experiences. So what this was back in the 90s, early 90s, Kaiser Permanente and a group working with them took a list of the 10 most predominant forms of trauma that exist out there. And they tried to see if there was a correlation with poor health outcomes later on in life. And sure enough, they found that. And what they found is that if you have 4 of these 10 adverse childhood experiences, and this includes physical, emotional, or sexual abuse, physical, emotional neglect, or mental health illnesses, incarcerated relatives, a mother who was treated violently in particular, substance use, or divorce, you were at a higher risk of having the following. So traumatic brain injuries later on in life, depression, anxiety, unintended pregnancies, HIV, STIs, cancer, diabetes, but also lower access to opportunities, key opportunities such as education, income opportunities. And again, these are horrible, horrible outcomes that can occur from adverse childhood experiences, but we don't look into it. And we know that there's sort of this ladder that exists with these adverse childhood experiences. So there's different contexts of these adverse childhood experiences. There could be historical trauma, social conditions. There's the adverse childhood experiences right in the middle, but this can lead to disruption in neurodevelopment, social, emotional, cognitive impairment. There then becomes an adoption of high risk health behavior. And then, of course, disease and morbidity secondary to that, and an early death thereafter. So these all sort of stack on each other over time. These are some stats from Edmonton in terms of numbers of individuals experiencing homelessness. This is the best I could find right now. These are all collected through what's called a point in time count that happens typically once a year. A lot of this was disrupted during the pandemic. So it's really hard to get new reports right now. And it was a bit inaccurate because they weren't sort of doing their usual outreach in terms of counting these numbers. But this is the number officially from 2022, 2519 is the total number of people experiencing homelessness. But we do feel that this is probably an underestimation. I think Dr. Mosaico could probably speak to that. But in terms of individuals experiencing chronic homelessness, it's about 65%. People experiencing episodic homelessness, about 35% is what they're saying. People staying in shelters is about 660. So this is sort of a breakdown again of homelessness in Edmonton. These are a bit more fun to look at pictures, and I stole this from Calgary. But these are a bit old as well. So this is from 2019, but the numbers haven't really changed as much. So it was about 2,900 back in 2019. And in terms of the demographics, they're very similar from year to year. It hasn't really changed again. The vast majority of our people who are experiencing homelessness are male, about 3/4, followed by females, which is about 1/4. And veterans make a huge proportion of this population. This also doesn't change year to year. From previous surveys, they found that about 7% of individuals had served in the Canadian military. And obviously this relates to trauma that they might have experienced in the past relating to their homelessness status. This represents about 39% of veterans found throughout the Alberta PIT count. So this is an Alberta stat. In terms of demographics, the vast majority of people who are also experiencing homelessness, and again, this stays the same almost year to year, is people between the ages of 25 and 44. 25 and 64, I should say. So that's the vast majority of people. That's the large demographic there. So 41% for 45 to 64 and 35% for 25 to 44 age ranges. Now, a lot of times we as healthcare providers think that homelessness is not our issue. It's not something that we need to tackle. But nothing could be further from the truth. There's a strong intersection between homelessness and health. We do know that homelessness complicates treatment and recovery. They often don't want to reach treatment services. They want to engage with us. They have difficulties reaching us. Health problems cause homelessness. So oftentimes we also see individuals who have had a traumatic event, whether it's a physical traumatic event, they had a broken bone, they had surgery of some sort, back surgery, and therefore they can't work, they can't function, and they get driven into homelessness. We also know that homelessness can cause health problems itself. So people who are on the streets, they get exposed to the elements, they'll get frostbite, they'll come in, they'll have amputations. All of this relates to health. So it's not an isolated situation. Health and homelessness are very much tied. And the same goes for social work and the social services. They often think that it's not really a health issue, but it really is in its core, in my mind. And there's numerous barriers to accessing healthcare resources for this population as well. So these can be broken down to personal reasons. So this is based off Maslow's hierarchy of needs. They often have different needs and different priorities than the rest of us. Their priorities are trying to get food. Their priorities are trying to get housing. Their priorities might not necessarily be their health. There's also issues with mental health capacity and motivation. There's personal barriers such as transportation. So if they live on one far side of the city, getting to their appointment can be very problematic, especially if they don't have money for public transport. There's also situations with security of personal belongings, including medications. Sometimes they have to leave their cart, say, outside of the facility. They can't bring it in, and they'd rather protect their belongings than come into the facility to get their healthcare needs taken care of. But there's also relationship barriers, and this is a huge one: stigma. I'm sure you've heard this before, but there's a large proportion of this population who have been traumatized by the healthcare system in the past, either by the way they've been treated, by the way they've been looked at, and I know that culture is changing within our health service systems, but many of them do remember that. They remember being ignored or being called a drunk Indigenous individual, for example. And so these are like horrible, stigmatic situations that they faced in the past, and infects their relationships later on and their willingness to engage with us as healthcare professionals. So in terms of working with this group and approaching this group, the key here is to understand that there's a difference in priorities for these individuals. And because there's a difference in priorities, you need to be flexible. So often the walk-in clinic model, such as one that Radius has, is often better than structured appointments, for instance. Medication dispensing, it can be problematic as well for these individuals. You have to look at getting Alberta Works for them to make sure that medication is covered. And so prioritizing getting that process in place before they get discharged can be hugely beneficial. And then also doing a broader examination of their needs. So it's not just about dealing with their pneumonia, dealing with their hypertension or whatever reason they got admitted to hospital for, but it's also looking at their baseline cognition levels, getting OT involved, for instance, looking at their mental health, screening for substance use issues, and then also getting social work involved early as well, so that they can start to examine housing capacity and in making sure they have wraparound supports around them. And there's also this other piece of understanding the intersection between justice and individuals experiencing homelessness. A lot of our individuals do have concerns with the justice system, with the correction system. They might be minor charges, of course, but it weighs heavy on them and prevents them from getting housing, for instance, prevents them from getting jobs, for instance. So it's important to sort of look at that, examine that, and see what we can do as health professionals to mitigate that. In terms of some other advice in dealing with individuals experiencing homelessness, the length of consultation should ideally be 30 minutes or less, if possible. I know for internal medicine, we sometimes go for an hour long consultations, or we have teams of residents still go in there repeatedly to see patients. But ideally with this population group, we want to keep it short. Their attention capacity may not be the best. On top of all of that, try to limit the physical exam to the first appointment or evaluation only. Many of these individuals have been traumatized in the past, and so doing a physical exam might be a bit more invasive than others might feel. So try to limit it to the first time you deal with this population and approach them. Also try to be trauma informed, and trauma informed, as you know, is sort of changing changing the frame of the way we approach this population from what's wrong with you to what happened to you. And that's the key. And there's what we call the 4 R's of trauma-informed care. So it's realizing that trauma is there and it has a widespread impact on this population group. Recognize the signs and symptoms of trauma, not just for the patient, but their families as well as other staff too that we work with. Respond to the trauma by integrating trauma, or integrating knowledge about trauma-informed care, and then resist resist re-traumatization, essentially. Try to resist re-traumatizing this patient group through exposing them to potential other traumas. So this includes things such as restraints, for instance, while they're hospitalized. So these are things that we can do to ensure that they're well. In terms of the 6 principles of trauma-informed care, it's ensuring that we provide them a safe environment, being relaying trustworthiness and transparency, trying to get peers or people who lived experience involved in their care, collaborating with them and trying to empower them, but also be very responsive to their needs and understand our own personal biases towards them and understand potential historical traumas that they might have faced in the past. Often we do see individuals have very complex behavioral concerns. And I often get this message from my colleagues all the time, like, how do you approach a complex behavioral patient? And really it's hard to do, but recognizing the trauma is one of the key pieces. Often if they're aggressive, it's sort of related to their fight or flight response from previous trauma. So they might fight back as part of the fight response. And so knowing again that they come from a place of trauma and understanding that can show and demonstrate empathy towards that can be helpful. Honor their independence, don't dictate to them. One of the big things that I suggest is try to provide them with choices and options, empowering them, again, using that trauma-informed care lens to help them out. provide motivational interviewing, and demonstrate that we're one and the same. They're not different from us. We're together as a community. We're there to support them. These are some key things that you can do for behavioral management. So in terms of mortality and homelessness, a lot of this work was done by a huge icon in the field, Stephen Wang, who's based out of Toronto and a great mentor. What they did was they did a prospective study between 2000 and 2009 in Boston. And what they looked at was the all-cause mortality rate of unsheltered individuals. And they found that it was 10 times higher for people who were rough sleeping than those of the general population. They found that all-cause mortality was about 3 times higher for people who are sheltered. So this is not rough sleeping now, they're staying in a physical shelter, than that of the housed population group. And the most common causes of death were non-communicable diseases such as cancer and heart disease being number one, and it still is high up there, followed by alcohol use disorder and chronic liver disease. Bear in mind, the study was done in 2000 to 2009, well before the opioid epidemic, the drug poisoning crisis, and I'll talk about that in just a bit. But in terms of healthcare utilization, homelessness, individuals experiencing homelessness are at higher risk of uncontrolled chronic diseases. They have a higher prevalence of mental health, addiction, infectious disease concerns such as HIV and Hep C, so things that you need to screen for on a regular basis when you're dealing with this population. They also use services much more. So in this particular study, they found that 71% of this population had used the emergency department in the last 6 months. And they found that in terms of length of stay, and this is from a different study, though not from the Boston study, that between New York and Toronto, the average length of stay spent in hospital for those experiencing homelessness compared to those who were stably housed was 2.3 more days in hospital versus 4.1 more days in hospital in Toronto. So this was a more updated study that was done at Johns Hopkins that looked at the impact of homelessness and mortality for people who are experiencing homelessness, and they found that this number has gone from 10% now to about 16 times greater than that of the housed population, and it's no longer cancer and heart disease that are impacting mortality. It's drug poisoning events. This is related to the opioid epidemic, the opioid crisis, if you may. We're moving away from opioid crisis towards the language of drug poisoning. And so this has hugely shifted the way this population is being affected. One of my favorite questions to ask the group is what the average life expectancy is of this population. And I want you guys to sort of throw your answers in the Zoom link if you can, in the chat box. But for males, typically the average life expectancy for someone experiencing homelessness varies between the ages of 35 to 45. And for females, based on whatever study you look at, it's between 30 and 40 years of age, on average 32. That's the life expectancy of someone experiencing homelessness who's on the streets. That's staggering. The average life expectancy for most Albertans is 80. So again, something to bear in mind. So one of the other things that we were trying to do was sort of look at healthcare utilization from an Alberta lens. So in terms of advocating for programming for this population, we did a study quickly in Calgary back in 2018, and we tried to see if there was differences in healthcare utilization and lengths of stay in hospital, in both emergency departments as well as inpatient wards for this particular population group. And so what we did was we did a retrospective cohort study. We looked at individuals experiencing homelessness who were accessing care in all 4 hospitals in Calgary, as well as the Sheldon Schumer Urgent Care Center. And we went through administrative data. So we looked at discharge abstract data, as well as NACRS, so the National Ambulatory Care Reporting Systems database. We also utilized ICD-10 codes, which went into effect in 2017. So these new codes, there was a newer code, I should say, that was there for homelessness that got activated, and we were able to use that code as well. But we also looked at people's status in terms of no fixed address, as well as their postal code, and if they had a postal code associated with the homeless shelter within Calgary. And we also looked at the mean differences in length of stay, and we adjusted this for age group, sex, as well as their diagnosis. We, of course, computated that. And what we found was that there was a total of 3,600 unique individuals who experienced homelessness, who accessed resources in Calgary between 2017 and 2018. And of these individuals, 858 of these people were admitted to hospital. We did a 1 to 10 comparator group. And so that was about 370,000 individuals. And we looked at all age groups, of course, as well. And what we found was that people who experienced homelessness who accessed acute care had on average 3.19 visits to the emergency department in that year. And when we looked at the lengths of stay in acute care settings, what we found was on average, they were spending about 3 more days in hospital compared to people who were stably housed. And this number went up to 7 more days in hospital if they were female between the ages of 25 and 34, or if they were male between the ages, less than the age of 25, between 18 and 25 years of age. So that's a huge difference. Of course, we didn't match based on severity of illness, which we couldn't do, but this was staggering to us that they spent on average 7 more days in the hospital. When you looked at the reasons for increased emergency department length of stay, we found that there was 31 diagnoses that were statistically significant for increased lengths of stay, and some of the key diagnoses that were associated with this included fevers and chills, synovitis, but more specific, more actually, I think the higher numbers were related to unspecified organic psychosis, mostly related to methamphetamine use, as well as schizophrenia, which led to a length of stay about 15 more hours in the emergency department. When we looked at increased lengths of stay for inpatients, there was 2 predominant diagnoses that were related to this. One was atherosclerotic cardiovascular disease, which had an average of 25 more days in hospital compared to those who were stably housed, as well as people who had preterm delivery, who spent on average 6 more days in hospital. So how do we deal with this staggering issue? And so I have a list here of 6 main approaches to dealing with this. First and foremost is to deal with the social determinants of health. So this includes assuring and evaluating for housing, income support, food, making sure they have medication coverage. These are all things that we can do within the hospital setting before they get discharged that can help with their overall outcomes. And we should also be doing this in community as well in an outpatient setting. A lot of this is based off the Chez Soi study that was done back in the day, where they looked at 5 different Canadian cities and they tried to get individuals into housing first situations. So before, there was this concept that you had to stabilize an individual first in terms of their mental health needs, in terms of their wellness needs before you got them into housing. And this study flipped that on its head. Essentially, what they showed was that if you provided them with housing first, plus additional supports, it just can't be housing, you just can't get them into a home, that this would increase their overall wellness. So, and they've looked at different aspects of the study, and they've shown that it decreases overall substance use, decreases relapse rates for substance use, decreased health service utilization, increased housing tenure, and improved health outcomes overall. So this is the key thing that we need to do. We need to get them into supportive housing facilities as our number one thing. This particular slide, I wasn't sure where to put in, but it's a very important slide. And Isabel was fantastic to remind me that I need to include this slide earlier on. But this was based off a systematic review. And what the systematic review showed was that for individuals experiencing homelessness, almost 50% of them had traumatic brain injury, moderate to severe traumatic brain injury. And the reason why I put this slide with the housing piece was because housing is a basic right, especially for people who have disabilities. And for this particular population, we're not providing them with that service. We're not providing them with that care. And it's something that we need to advocate for and do for this population group. Another approach that we can take is specialized, centralized general support. So it's a sort of one-stop shop support for this population group. So for instance, Radius does this work. So Dr. Francesca Mosaico is here today, and not only do they provide health services for this population, but they also provide social supports for this population group as well. They provide them with access to dentistry, optometry, podiatry. There's food provision there too. So it's a one-stop shop for all of their needs, which is why these services such as Radius are super important to have. Another thing that we need to work on is discharge planning, coordinated care. And so we often don't do this well. And one of my future plans is to create a discharge bundle for this population group. But it's really about ensuring that you have appropriate discussions about during discharge about getting them to safe housing, coordinating the community resources such as Radius, making sure that they have the appropriate aftercare, including foot care and dental supports if possible, and ensuring that basic needs are taken care of, including transportation. Something that we can do as physicians is screen them for HIV, Hep C, etc., ensure that they get treatment afterwards, and then also make sure their vaccinations are up to date. And this includes getting their influenza vaccine up to date. Pneumococcal is important for this population group as well. These are all things that we can do while in the inpatient setting to help support this population group. The fourth big thing that we can do is provide linkage to care. This can be done through community health workers. My favorite example of this is peer workers, so people with lived experience who have walked the walk of substance use and homelessness and can now talk the talk. They've navigated the systems before, and we know this helps out. So this was just an example that from a pitch that I tried to give a long time ago about what happens to people who use services. And so we tracked people who had presented to the emergency department in Calgary zone, and we tried to see what happened to them afterwards. And we found that only 20% of them actually accessed the services they were supposed to access upon discharge. This included inpatient addiction services, places such as the opioid dependency program, harm reduction services such as the supervised consumption site. What we found as well was that less than 1% of them actually accessed primary care thereafter at CUPS or the Alex in Calgary. Our hypothesis was based off of a previous study that was done in Rhode Island, where they found that when you paired some of the person with lived experience to help them navigate the system from the emergency department into community, and this can be acute care as well, this can be inpatient wards as well, that this number increased to 83%. So there was a study that was done in Rhode Island in which people who showed up with an opioid overdose event or drug poisoning event were paired up with a peer, and previously 30% of them engaged with services, similar to our 20%. And that increased to 83%. There was a recent study that was done in Alberta through Patrick McLean from the Emergency SCN, what he found was this number was about 43% now, but we can improve this number drastically by using peers, using community health workers, using navigation services from acute care settings. And so these services can be these navigation services can really be the connective tissue between services, making sure that people reach the appropriate services and navigate the system, which can be very, very complex. I know as a healthcare professional myself, navigating the system is hard for me and trying to figure out where to send patients and what to do. So you can imagine what it can be for them when they have mental health concerns, substance use concerns, traumatic brain injury. They need help, they need assistance, they need some handholding. The next thing that's out there is intensive case management. So a great program that exists in Calgary is Connect to Care. This program consists of case teams. So this includes a nurse, a social worker, a case manager, and sometimes a peer, where they coordinate the care around an individual and help transition them into the community. And this program in Calgary has demonstrated lower ER visit rates, improved engagement with primary care and community programs, reduction in homelessness, and it's shown to be cost effective as well. Something that we can think of doing in Edmonton. And then outreach is another aspect of something that we can do too. So right now, Edmonton does have the community paramedic team, also known as Mobile Integrated Health. It's easy to contact them. I'll try to send their contact info later on. I use them quite often to help with my patient population group and do checkups on them after they get discharged. They're there to provide support. Another team that exists in Calgary is the CAMP team for palliative care. I know that there's an Edmonton palliative care team as well. I just can't remember the name of it. But a lot of this is based on the principles of street medicine. So this is going to them instead of expecting them to come to us. So street medicine often involves small teams of doctors, nurses, and clinicians who will walk the streets of the downtown cores, the inner cities, and see patients where they're at on the streets, have kits with them in their backpacks to help provide support, and if necessary, get them to where they need to be to get additional support, such as a treatment facility, an emergency department, etc., if they can. So these are all important things that we can do. The last thing that we can work on for this population group is medical respite. And this is, these are all 6 of these are evidence-based. But we're going to sort of hone in right now on medical respite. And it's a space, a patient-centered space where people can go to when they're too sick to be on the streets, but not sick enough to be in hospitals. And this can include acute, post-operative, perioperative supports. These are safe discharge options from hospital, and it's really a transition space for individuals between community to hospital, as well as hospital to community as well. My favorite sort of analogy of this concept to sort of convey to our healthcare providers is that for individuals, so for us who are not experiencing homelessness, if we have appendicitis, we go to the emergency department, we might get put on antibiotics, we might get an appendectomy, we spend maybe 1 to 2 days in hospital, and we're told to go home, get some bed rest, don't go to work for 1 week. Easy for us to do if we have a bed to go to, but for someone experiencing homelessness, that option isn't there. And so this space can be a space for them to go to. And there's 4 key components to medical respite. This includes clinical care, so clinical oversight, and 24-hour bed rest, case management, so outreach, wraparound services, including housing support, integration into primary care and or addiction support, as well as self-management support. So making sure they get education, making sure that they understand what the next steps are in the recovery. These are all key components of medical respite. And there's a variety of different medical respite programs that are out there throughout the world. So these are apartment motel rooms, homeless shelters and outreach into these shelters, transitional housing, assisted living, nursing homes, as well as standalone facilities. So the concept behind medical respite began in the 1980s as a concept where it would be a transition spaces between acute care and community. Within the early 2000s, the United States government provided funding for 10 pilot projects. By the early 2010s, they were finding that it was very cost effective. And so they began to create networks around this. And today we have tons of programs in the United States that provide medical respite, yet we don't have a comprehensive medical respite program in Canada as of yet. We have a few programs that are similar to medical respite in Canada, but they're tailoring towards specific populations, such as men who are drinking, for instance, in Ottawa, or women who have substance use concerns in Vancouver, but nothing comprehensive the way that they have these programs in the United States. So currently in the United States, they have 116 of these programs. Their bed capacity ranges from 5 to 124. So I was at the Boston Medical Respite Program a couple of years ago, and they had, I think they had about 70 beds. The median number of beds is about 17. Staffing for these services varies. They vary from full-time practitioners to nurses, just nursing supports, to robust teams of providers and specialists. And some have inclusion criteria such as independence in terms of activities of daily living, or limits on substance use concerns as well. In regards to the top referral diagnoses for these facilities, these include cardiovascular disease, management of diabetes, HIV management, post-operative care, psychiatric concerns and psychiatric care, upper respiratory tract infections, skin infections, including abscesses, frostbite, and foot infections, as well as substance use management and general wound care. In terms of the 4 components of medical respite, there's medication assistance, access to primary care, support for follow-up appointments, and case management as well. And this includes wraparound supports for this population group. And these are some of the standards that they've published more recently on medical respite. So these just came out about 4 weeks ago. And these are great standards to sort of abide by. There's plans in the future to sort of do an evaluation process in the United States around these programs to make sure that these standards are met and followed through with. So the United States is actually undergoing a formalized process around this. And a lot of this work is, funny enough, being supported by the insurance companies. So a lot of this work is actually being funded currently by Kaiser Permanente nationally, even though they're mostly predominant in Western United States. So I mean, if the insurance companies are supporting this, what this tells me is that this is something that we need to do here in Canada as well. Here's sort of a case example of a person who accessed medical respite in Cincinnati. So this individual was a high systems user. His name is John, and he was using the emergency department or inpatient services about 19 to 20 times per month. On average, 19 to 20 times per month. But every time they utilized medical respite, that dropped down drastically. So as you can see here in January 2006, that it went down to about 9 times per month. In September, they accessed medical respite, and that went down to 4 times a month. But once they got permanent housing, their utilization of the services decreased drastically for the first year. And after that, they stopped using healthcare resources for the next year thereafter. So this service really does work. This is from a cohort study that was done respectively in Chicago, from Buchanan et al. And essentially what they found was that when they looked at a cohort of individuals who experienced homelessness, who were eligible for medical respite, and compared those to individuals who were eligible but could not access these sites, they found that the patients who could access these sites had 58% fewer inpatient days within 12 months, and had a 49% decrease in admission to hospital, and a 36% reduction in emergency visits altogether. which is huge. There was a systematic review that was done in 2013. There has been an update since then, which means that it's probably due time to do an update. And they had about 13 studies that they reviewed. So these are heterogeneous in their perspectives of 1 RCT, 2 retroactive cohort studies, 10 observational studies, and they found that overall medical respite programs do decrease future hospital admissions and decrease future lengths of stay in hospital. This is the Buchanan study on the right-hand side again, but I want to compare it to the left-hand study here that was done by Biderman, which they found statistically significant decreases in hospital admission rates. They did a very similar study, I should say, to Buchanan. They found 70% decreases in patient days. But what was also interesting was they looked at whether or not these individuals accessed outpatient-based services, and they found that there was a 192% increase, which is statistically significant for these individuals to access primary care. Which is hugely important for us because we want them to be accessing primary care and not using our acute care services. This is one of the more recent RCTs that was done in 2020 in Denmark. And what they did was they compared 2 groups, one who's offered a 2-week medical respite care stay at a Red Cross facility, whereas the other was not, and was discharged to usual care and to usually typically shelters. And what they found was that and this is more of a cost effectiveness study, that at the 3-month and 6-month groups, about 8,000 euros were saved with the group that accessed medical respite compared to those who did not. What they didn't really dive into was the healthcare utilization. They just display this table here, but as you can see, the intervention group who got medical respite accessed acute care services as well as emergency services at half the rates of those who didn't access medical respite. So that's huge in my mind. This was a very crude cost analysis that we did in Calgary to try to advocate for this program. So we, on average, the average length of stay in hospital is about 8 days. The cost for anybody, that is, people experiencing homelessness are about twice that number at times. The average hospital cost per day is about $1,000. Respite costs per day vary between $68 and $350. So we estimated that roughly we would save the system about $4.6 million a year through a reduction in ER visits using previously determined numbers from other studies at 24%, reduction in lengths of stay by 42%, and a reduction in readmission rates by 50%. The other thing that we did to sort of advocate for the work for respite in early days was we consulted people with lived experience. We talked to people who were experiencing homelessness and asked them what they needed. And we also looked at various surveys and reports as well that we had conducted. And the key thing that came about with this was very much similar to what this particular study had done, was that that basic needs are their highest priorities, that medical respite can work for them, but it has to be paired with social supports, which is just as important to them as healthcare. And they need to have a very safe environment to reach recovery, to have recovery. And that having these spaces helps with their own self-reflection, with their own wellness, with their own stability. With that, I'm going to pass it over to Jacob to talk about what we're doing in Edmonton here. Just to frame this, a lot of the work that was done around this was sort of the silver lining from the pandemic. So during the pandemic, Jacob, along with Isabel, along with Francesco, along with a large, broader team, helped provide supports for individuals experiencing homelessness to isolate during the pandemic. And so we utilized that model to help advocate for respite work later on down the line. And so, Jacob, I'm just going to pass this over to you.
Yeah, absolutely. Thank you. So just to highlight, in Edmonton zone, so Monty and Isabel have been working with our AHS co-chair group and looking at how to implement medical respite care programs across the province. And in Edmonton zone, we were first out of the gate with this, with the Respite to Recovery program operated by Radius Health and Healing. And really at its core is it's a place for people to recover and have some access to healthcare supports who are too sick to recover in while sleeping rough or in a shelter setting, but not sick enough to be admitted to an acute care site and warrant a hospital stay. And kind of why this program works is because we know after exiting the pandemic, We've seen a sharp increase in homelessness, especially in Edmonton and Calgary. And also, we know at our acute care sites, we have an increase in the amount of people who are showing up to our EDs with higher acuities and warranting longer stays in acute care, which is creating a lot of pressures on our system to get people out the door quicker. And we just need a place to be able to send people who fit this criteria. Next slide, please. So in the Edmonton zone, the model that we got approved for is an AHS funded program, which is Respite to Recovery, in partnership with Radius Health and Healing and the Mustard Seed. And essentially what this program does is we work together to facilitate safe transition of care from our acute care sites and community into the R2R program, which is a nurse-led bed-based care program inside of a shelter setting that is supported by AHS InReach services. So AHS provides the healthcare dollars, and Radius provides the healthcare and medical oversight. And then the Mustard Seed provides the space that we operate the program in, and that includes cleaning and food as well as security. And then once a patient is in the R2R program and they're receiving care, Radius can help connect people to primary care services in the community as well as other social supports. And the Mustard Seed also has some supportive housing options and social supports that we can work together to connect people to. Next slide, please. So like I said, this program is really designed to fill a gap in care for people experiencing homelessness who have these healthcare needs that are not serious enough to require medical care or hospitalization, but too complex to be managed alone in a shelter or on the streets. Part of our big reason for wanting to fund this program had to do with the acute inpatient care sites and emergency sites and making sure we have a place to send these patients. But we also recognize that by having community referrals supported by the site as well, we can help divert traffic from the ED in the first place and get people accessing care earlier. So we're supporting referrals from all sorts of community sites, other shelters, as well as our acute care sites. And I just wanted to highlight our length of stay estimates for this program. We just have two different kind of projected lengths of stays. So if people are coming from an inpatient unit, we're looking at 2 to 4 days because they would have been already receiving care for 5 to 10 days at the hospital. And if they're coming from a community source for referral, it would be a 5 to 10 days. But we also recognize that some complex cases require an extended length of stay. And this might have to do with something like a very severe frostbite that requires some complex wound care. Next slide, please. We also wanted to highlight some of our inclusion and exclusion criteria for the program. And this is just to show what this program is and isn't. So for inclusion criteria, patients need to be experiencing homelessness or accessing emergency shelters, and they need to require health support. So something that they would need to receive care from the nursing staff for. But they also must be medically stable and meet criteria for safe discharge. And this is because we don't have 24/7 nursing oversight at the program. So they just need to be stable enough to be supervised by the shelter staff overnight, who call EMS if anything goes wrong during those hours. And then exclusion criteria really is around anybody who needs continuous monitoring, such as oxygen and IV therapy. And then it's also not like a detox site or a place for people to be waiting for long-term care, because then we would be filling up too quickly with people who are on those wait lists. So it's really about that short-term recovery period. Next slide, please. Temporarily in our location. So we opened up on October 4th and accepted our first patient on October 5th. And our hours of operation at the Mustard Seed Neighborhood Center is Monday to Friday from 8 till 4. And we currently have 15 beds at that site. And I just want to note that we are working to move into a new location within the next few weeks. Hopefully that we'll be able to extend that nursing coverage to 7 days a week from 8 till 11 p.m. And we'll be able to expand the beds from 15 to 27. Next slide, please. So I mentioned a little bit about AHS in-reach services. These are some in-kind supports that we provide to R2R through addictions and mental health intensive services, our EMS mobile integrated healthcare team, as well as home care. And we also provide some infection control and environmental public health supports as well. And these are all secured through referrals made by the nursing staff at the R2R program. Next slide, please. So just some of the nurse-led health services that are provided with the physician and nurse practitioner oversight at R2R. We do the chronic disease management, complex wound care, some foot care. We also do pre-op support. So anybody who would need a colonoscopy and has to do bowel prep would be able to stay there for that period, as well as any kind of post-op supports as well. And then there's R2R also supports care coordination with their main clinic and provides the dental care and occupational therapy programs through their site. Next slide, please. For now, how we're set up, referrals have to be made through a phone call to the R2R intake nurse. And this is because we really need the discharge planning at the acute care sites to have that conversation to ensure that R2R can support the patient before they arrive, and making sure that we're sending over any medication that they need for the bridge doses until we can support securing their medication from the pharmacies. So we're not able to support any type of fax referrals because that conversation needs to take place before we set up the transition. Next slide. So in order to get this program funded in the Edmonton zone, we were asked to set up a value proposition. So working with some of the work that Monty did in Calgary zone and building off of the model, we decided to kind of detail out what the status quo is in our system pressures in Edmonton. So we know we did a 3-year look back and found we have like 54 ED visits per day from the homeless population, which results in almost 7 inpatient admissions every day. And the length of stay for this is almost 13 days, giving us an average census of just about 76 homeless patients in a hospital at any given time in Edmonton, which is an annual cost of around $32 million. Next slide, please. So just for the sake of ease in this value proposition model, we kept the patient flow into our inpatient sites as the same. And we thought, what would change if we had a medical respite unit as an intervention? And through some research, we knew that people who are homeless stayed in an inpatient bed anywhere between 2 and 4 days longer than somebody who is housed. So we thought that the MRU intervention would be able to be a place where we can discharge people at least 2 days earlier. And that this would end up reducing our average daily census by almost 10 people and would result in an annual cost of $28 million. So that's about a $4 million difference annually for this population. Next slide, please. So this is just highlights some of the calculations for how we arrived at our return on investment. And with that $4.4 million of value created and our estimated cost of funding this program at $1.6 million, this would be a 2.78 return on investment for providing this service in the community. And I just wanted to highlight that this is our healthcare budget that we're looking at, and we acknowledge that the social agencies cover the non-healthcare budget that's attached to this program. So the real cost of this program is much higher, and it wouldn't be possible without the partnerships that we've secured in the Edmonton zone. And I think Yep, back to you, Monty.
But in terms of future directions, we definitely want to look at IV therapy, palliative care, and then substance use for pregnant patients as well. And look at the virtual model as well, and the virtual home hospital model too, to see how it can integrate. Thoughts for the future. But with that, we're going to open up the floor to questions, and happy to sort of discuss. And I'm glad that we have Dr. Mosaico here, as well as Isabel, to help answer some of these questions as well.
Thank you. You guys are doing outstanding work. I think with this area, sometimes for those of us who, sort of look after inpatients and see these patients in our clinics, it feels like we're boiling the ocean. So the fact that, you're doing some real objective interventions that will be helpful, I think, with hopefully expansion will be really important. I just have a very quick question, and this might be, I don't know, considered political, I guess. With the recent announcement with continuing care sort of being taken outside of the AHS sort of umbrella of mandates, do we know whether or not this is going to have an impact on the work that you and Isabel are doing, for example? Recognizing that Radius is sort of outside that umbrella, I guess, but just wondering if you've gotten any information about that.
I'll hand it over to you, Isabel.
Yeah, we've actually been working very closely with many partners. It's this group of clients really requires a whole of government approach. There's so many ministries that need to step up and participate. So I don't think that it will be more challenging, because I think that everyone is committed to integrate, and we do have all of those players already sitting around the table. So, but I have to say it is, I mean, you just have to be like a dog with a bone to keep pushing this agenda forward. And we were actually really fortunate. About 10 days ago, Alberta Health Services executive team approved medical respite program for the other zones in the province, about $6 million. So again, that will require close collaboration with other ministries, because just as Jacob has shared, I mean, we're just one piece of, the solution. So the work carries on.
Yeah, there's lots of great comments in the chat. In particular, Dr. Lewanchuk really appreciates highlighting that this is us. This is not, them versus us. This is all of us. And so really thinking about that. And then Dr. Karen Lee has put in some references in terms of the healthy housing work that her group is doing, which hopefully will be presenting in a future grand rounds. And then lastly, some resources in terms of where funds can go for individuals wanting to contribute to this really important cause. So thank you. I know we don't have very much time. I don't know if there's any sort of burning questions. I don't see anything in the Q&A either. So with that, I think we will wrap up. But thank you so much for an outstanding presentation, making us aware of this important resource, particularly for those of us, as I said, who look after inpatients. I just need to make a couple of quick announcements. Number one is we have the Department of Medicine is sponsoring a TGIF today. So for those who have a chance to attend, it's in the faculty area down in Kate's, on the first floor. So between 4 and 6, hopefully you can attend. And then next week we have our annual Gardner King lecture, which is around post-COVID recovery and wellness. Really outstanding speaker that we've got planned. So hopefully you'll be able to make it to that. And we plan to have a little reception after that. So if you can come in person, you'll get a little bit of goodies afterwards. So with that, thank you everybody and have a wonderful weekend. Take care.